This presentation is over bicipital tendinitis, most commonly referred to as biceps tendinitis, but may also refer to biceps tendinosis, which I'll discuss later. The involved anatomy for bicipital tendinitis includes the three bones that make up your shoulder: the humerus, which is your upper arm, the scapula, which is your shoulder blade, and the clavicle, which is your collarbone. This also involves the glenoid, which is the socket that your upper arm fits into. This also has a soft cartilage in it called the labrum that helps the head of your humerus fit into the glenoid. The rotator cuff muscles are also involved, and they are the group of muscles and tendons that help to keep your arm centered in your shoulder socket. The biceps tendons are from your biceps muscle. There are two of them, one long head that attaches to the glenoid, which is your shoulder socket, and the other, the short head, that attaches to the coracoid process, which is a bump on the shoulder blade. The pathology of bicipital tendinitis is generally a secondary impingement of the biceps tendon. Possible secondary impingements may be caused by scapular instability, other shoulder ligaments that are unstable, a laxity of anterior capsule of the shoulder joint, or tightness of the posterior capsule of the shoulder joint. Bicipital tendinitis may also be referred to as biceps tendinosis, which is caused from overuse or degeneration of the tendon. Looking at the picture on the right, you can see a normal shoulder and biceps tendon. Then looking at the bottom picture, you can see a red and swollen biceps tendon in the shoulder joint that has biceps tendinitis. The predisposing factors for bicipital tendinitis are old age or aging. As we get older, our tendons get less flexible, thus making them more prone to injury. Also, any job or sport that has a lot of overhead activity or repetitive movements can put the tendon in an awkward position and stretch it, causing the tendon to get overused and degenerate, causing biceps tendinosis. Lastly, having improper technique in sports such as swimming or baseball could cause the tendon to be under more stress, thus causing more damage and inflammation on the tendon. The most common mechanism of injury for bicipital tendinitis is a lot of repetitive overhead movement, because this tends to overuse the biceps tendon. Having improper technique in a heavy upper extremity sport such as swimming or baseball is also a big mechanism of injury for bicipital tendinitis because of the strain this puts on the biceps tendon. When you have bicipital tendinitis, you may experience a sharp pain in the front of your shoulder when you reach above your head, behind your back, or across your body. You may also experience tenderness to the front of the shoulder or pain that radiates down the arm or towards the neck. You could also have a dull, achy pain in the front of your shoulder, especially after activity. Weakness felt around the shoulder joint may also occur. You could also have catching or clicking coming from the front of the shoulder with movement. A differential diagnosis of bicipital tendinitis is impingement syndrome because of where the pain starts and radiates, as well as because it has the same mechanism. Also, adhesive capsulitis because of the pain being worse at night, and subacromial bursitis because of where the pain is located and the movement that causes the pain. There are four main special tests that test for bicipital tendinitis. They are Yergason's test, Speed's test, Ludington's test, and the uppercut test. For the explanation of each test, I turn to physio tutors. First, we'll look at Yergason's test.
The Yergason's test was primarily designed to test the transverse humeral ligament, which holds the long biceps tendon in the bicipital groove. According to a research done by Micharoli et al. In 2015, it has a sensitivity of 32% and a specificity of 88% for biceps pathology. Furthermore, a research done by O et al. In the year 2008 showed a sensitivity of 12% and a specificity of 87% for slap lesions. To perform the test, have your patient's forearm flexed to 90 degrees in full pronation and stabilized against the body. Then ask your patient to perform supination and resist the movement. At the same time, make sure that you palpate the biceps tendon in the bicipital groove. If you feel the biceps tendon popping out of the groove, this indicates a tear of the transverse humeral ligament. Tenderness or pain without the pop is indicative for biceps tendinosis or slap lesions.
Now we'll look at Speed's test.
Originally, the Speed's test was designed to test for tenosynovitis of the long biceps tendon, but is now being used for several pathologies of the biceps. In their meta-analysis from 2012, Hedges et al. Found a sensitivity of 20% and a specificity of 78% for the Speed's test in the detection of SLAP lesions in the shoulder. The test scored equally low in the detection of biceps tendinopathy in several other diagnostic papers. For this reason, the Speed's test has a low clinical value to in or exclude SLAP lesions or other biceps pathologies. The literature describes two different performances of the Speed's test. For the first version, ask a patient to extend his elbow and fully supinate the forearm. Then, the patient flexes his shoulder from 0 to 60 degrees while the examiner gives resistance. This is probably how Spencer Speed discovered the test himself, as he was experiencing pain in the shoulder when he was performing a straight leg raise test in his patients with an outstretched arm. In the second version, which is the version that is commonly used nowadays, the patient is asked to extend his elbow, fully supinates his forearm again and brings his shoulder into 90 degrees of flexion. In this position, the patient is asked to resist downward pressure. When a patient's arm is placed in the examining position for the Speed's test and downward pressure is applied, the biceps tendon acts like a suspensor cable from its insertion on the superior labrum to the arm. Increased tension in this cable, and if inflammation is present, is thought to result in pain in the shoulder. So in both cases, the test is positive if your patient reports pain in the bicipital groove where the long tendon of the biceps enters the shoulder capsule.
Next, we'll look at Ludington's test.
Hi and welcome back to Physio Tutors. If you followed our channel for a while, you may remember a series of videos we did on distal biceps tendon ruptures. However, it's more prevalent that the proximal tendon of the long head of the biceps tears. One key feature is the Popeye sign that looks quite something like this. Ludington described a case study of a worker who felt a sharp pain in the anterior shoulder after lifting a crate. Suspecting a rupture of the proximal biceps tendon, he proposed a new test to assess the integrity of the long head of the biceps tendon. However, this method has never undergone diagnostic accuracy assessment, thus the clinical value remains questionable. To conduct the test, the patient is in sitting or standing position. The patient is asked to place their hands on their head and to interlock the fingers so they support the weight of the arms. In this position, the biceps can relax as much as possible. Place 2 fingers over each long head of the biceps tendons and ask the patient to contract and relax both biceps simultaneously. In a positive test, the contraction is not felt on the affected side compared to the unaffected arm.
Lastly, we'll look at the uppercut test.
Keller et al. From the year 2009 found a sensitivity of 79% and a specificity of 78% in the detection of biceps tendinopathy, and the uppercut test was the most accurate test compared to other traditional tests in their study. For this reason, we give this test a moderate clinical value to in and exclude biceps pathology. To perform the test, your patient's shoulder is in neutral position and he is asked to flex his elbow to 90 degrees, fully supinate the forearm and to make a fist. The examiner then covers the patient's fist with his contralateral hand and asks the patient to rapidly bring their hand up and across the body towards the chin, like in an uppercut punch in boxing, while the examiner gives resistance. This test is positive by pain or a painful pop over the anterior shoulder. The authors reason that the uppercut test performs better than traditional tests as the contraction of the biceps is isotonic instead of isometric, and the traditional tests do not require arm motion. During the uppercut test, the arm is moved into flexion and slight internal rotation, which requires the biceps to be activated concentrically and to be moved in the bicipital groove with arm rotation. This combination of isotonic muscle activation creating tension in the muscle and the simultaneous dynamic rotation of the arm is thought to be the basis for producing symptoms. Keller did a regression analysis in their study and found that the combination of the uppercut test and the speeds test was the best model for detecting biceps lesions.
Immobilization is only necessary when the bicipital tendinitis is to the point where surgery is needed, because we don't want to cause adhesive capsulitis. If our special test reveals a possible tear in the tendon, we may want to refer to get an MRI, X-ray, or ultrasound to either confirm or deny our thoughts, so we may proceed with the best plan. If after treating the non-surgical route and nothing is helping, then we may refer to a surgeon for the surgical route. Also, we may have to refer to physical therapy to rehabilitate the patient. After a diagnosis of bicipital tendinitis is made, there are two paths you can take. The first path you can take is a non-surgical route. This includes resting by avoiding activities that cause pain, ice to help keep swelling down, and non-steroidal anti-inflammatory drugs, or NSAIDs, to help with pain and swelling. There are also steroid injections, such as cortisone, that are used as a very good anti-inflammatory medicine that can also relieve pain. Lastly, there is physical therapy that focuses on specific stretching and strengthening exercises to help restore range of motion and shoulder strength. If the non-surgical treatment is not working, then your physician may recommend surgery. These surgeries are usually performed arthroscopically, as shown in the top picture on the right. Rarely, the biceps tendon can be repaired, where it attaches to the shoulder socket. Biceps tenodesis is a procedure in which the damaged section is removed and the remaining tendon is reattached with a screw to the humerus, as shown in the bottom right picture. In some severe cases, tenotomy may be performed. This is a procedure that occurs if the long head of the biceps tendon is so damaged that repair and biceps tenodesis is not possible. In this procedure, the surgeon will release the biceps tendon from its attachment. This procedure is more invasive and may result in a Popeye bulge in the arm. Overall, complication rates are low for the surgical option. After surgery, you will have to go through a rehabilitation program prescribed by your physician, as well as you will have to wear a sling for a few weeks after surgery. There is no specific mulligan technique to relieve pain caused by bicipital tendinitis. There is one manual technique that is for the shoulder that may or may not relieve pain caused by bicipital tendinitis. This is the posterior glenohumeral mobilization. This is performed with the patient supine and the therapist's force hand on the proximal humerus. The mobilization is a posteriorly directed force directed perpendicular to the humerus. To prevent bicipital tendinitis, you should avoid certain activities that put more stress on your tendons or cause more pain. Try cross-training so you give your biceps tendon a rest, as well as helping you to avoid activities that cause pain on your biceps tendon. Improving your technique will also help to prevent bicipital tendinitis, because flawed technique will put your tendons under more stress and causing bicipital tendinitis. Lastly, proper stretching and warm-up before your activity could also reduce the risk of bicipital tendinitis. The article I chose to look at for my PICOT analysis was over the effectivity of arthroscopic release of the biceps long head. The population was 40 patients that had been diagnosed with a biceps disorder. The intervention was arthroscopic release of the biceps long head. The comparison was between whether or not the arthroscopic procedure was effective. The outcome showed that the arthroscopic release was successful. The time of this study was 2.7 years. Thank you for watching, and I hope you enjoyed this presentation over bicipital tendinitis.